towards afternoon. Let's see if this thing works. Good. Feels really good to be here presenting this talk, in part because it was 4 or 5 years ago, that I presented a talk at this conference on this same topic with no data, which felt very scary for me. It was a theory-only talk about the possibility that stereotype threat is relevant to think about in thinking about the healthcare experiences of LGB individuals. Very slowly got the data, and yay, get to be here 5 years later to now present some data to you on the same topic. So we're going to talk about healthcare stereotype threat and health outcomes in a national probability sample of LGB individuals. Oh, I have this, and I'm doing that. So we know that there are health disparities on a whole variety of indicators, ranging from mental health, physical health, tobacco use. Here are some citations. I'm not going to spend time on this, as it's well documented and continues to be documented over time. So a new paper recently came out by Gonzalez and Henning-Smith using more nationally representative data. Same patterns in this, looking at indicators like depression, suicide ideation, similar things. Same pattern as you get across time. LGB people looking worse on these indicators than their heterosexual peers. Lots of people have tried to explain these health differences, and the explanations range from things like increased prevalence of HIV and AIDS, particularly amongst gay and bisexual men. Things like lack of access to health insurance. Minority stress has been a big one, looking at Elon Meyer's framework, the minority stress framework, looking at how two particular classes of stressors, distal stressors, stressors that emanate from outside of the individual, most classically thinking about experiences of discrimination and how they impact health outcomes. And then proximal stressors, stressors that emanate from within the target individual. A couple classes of proximal stressors include perceptions of stigma, so the fear that other people will judge you negatively when you out yourself, when you reveal your sexual orientation, and then internalized homophobia, an internalization of society's negative evaluation of LGBT people. I, in thinking about these health disparities, wanted to kind of add to the list of proximal stressors in particular, thinking about stereotype threat as a potential proximal stressor that LGBT people face on a regular basis that may interfere with the encounters that they have with healthcare providers. Wrong thing. There we go. Stereotype threat, I assume most people in here know what it is, but in case folks don't, stereotype threat, as laid out by Claude Steele and Josh Aronson, is the fear of being judged by or reduced to negative stereotypes about one's group. And we know across now 20 plus years of research that stereotype threat can lead to anxiety, that it can lead to performance decrements, and that ultimately it can lead to disidentification with domains where the stereotype is relevant. And so stereotype threat is, you're never gonna be able to read that. Theorized to work like this. So there are sources, situational cues that exist in an environment that make stereotyped identity salient. So solo status could be one of those, cues that prime one's identity in the context. This then leads to a set of internal mechanisms, things like anxiety, negative cognitions, physiological arousal, reduced performance expectations, reduced effort, reduced self-control, working memory, which can have consequences. Things like impaired performance, discounting performance feedback or the validity of the feedback, disengagement, disidentification, changed aspirations. The vast majority of this work, looking at this model, has been done so in performance domains and particularly in academic domains. So how do stereotypes about intellectual superiority or inferiority of a group cue these kinds of fears about judgment based on those stereotypes, which can lead to these downstream effects. I've been interested in particular, and others, how this plays out in healthcare environments. So a non-performance domain, but a domain nevertheless in which stereotypes are often raised and in which one can come to fear that the person providing healthcare might judge them based on those stereotypes. So in particular, priming, do these contexts prime certain identities which lead one to have anxiety, negative cognitions, physiological arousal, and less concerned here about reduced effort and, again, performance outcomes. It's more what's going on psychologically, which can lead to disengagement and disidentification. So some people, including Diana Burgess, Jack and Video, have theorized that this is a model that might apply to health encounters, particularly of racial minorities. I've been, of course, interested in looking at this with sexual minorities, but prior to getting there, I had done some work, no, wrong way, looking at this with regard to other identities, not sexual minority identity. So in one study that I did with a colleague of mine, Cleopatra Abdu, we looked at older adults in a sample, the health and retirement study, and we asked them, when you visit the doctor, do you worry that the doctor or other medical staff make judgments about you because of your, then it was race, ethnic background, gender, age, weight, money, or other reasons? And if they said yes, do you worry that these judgments affect the quality of health care that you receive? And do you worry that you might act in ways that justify these judgments? So again, getting at, do you worry, do you experience at an explicit level this stereotype threat? What we found in this correlational work was about 17% of the sample reported experiencing stereotype threat based on one or more of their identities. I'll be honest, that number surprised me. I actually thought it was going to be higher than that. Again, it's a particular sample of older adults, so not representative of an entire population. With age and weight in this sample being reported more often than others. What was most interesting to me was that of these folks who are reporting experiencing these threats, you can see that there's a lot going internally. 34% of those folks also reported that they worry that they might act in ways that justify these judgments, and 41% believe that these judgments could affect their care. So there's, again, this kind of anxious reaction going on in these encounters potentially with healthcare providers. We also did some experimental work. I'm not going to explain that, it takes too much time, but we found in a sample of African American women who we had go through a simulated healthcare environment where they were in a virtual waiting room where we primed stereotypes about black women. They were led to believe they were going to have an encounter with a physician, an online encounter. And for women who highly identified with their racial and ethnic identity, they experienced significant increases in anxiety when in this stereotype threat condition than not. White women, you didn't see this. Okay? So now let me take you to why I'm here today, which I'm probably out of time, but we're going to do it anyways. Oops, I keep going the wrong way. So I want to talk quickly about some new data that I have looking at a sample, a national probability of sample of LGB people. I was really fortunate to partner with the Generations study. This is a study being done by Alon Meyer and others, where they use Gallup polling to get a national representative sample of LGBT people. So Gallup interviews like 1,000 people a day, random digit dialing. And as part of this inclusion in this study, they asked people their sexual orientation. And then to the extent that they reported a sexual minority identity, they were included in this sample. They also limited the sample based on ethnicity. So we only have folks here who are African American, Latino, and Caucasian. The study, the generation study, is a 5-year longitudinal study that is particularly interested in looking at stress and health experiences across 3 cohorts. I'll be honest, when I started this work, I wasn't so much interested in the cohort differences. I was just interested in demonstrating that stereotype threat exists in LGB people's healthcare experiences. But they have these 3 cohorts, and it's going to become relevant in a second. The equality cohort, people who are between 18 and 27 years old. The visibility cohort, 32 to 43. And then the pride cohort, those 52 to 61. I'm going to call these the younger, middle, and older cohorts. I didn't really have specific predictions going into this as to how healthcare stereotype threat might differ. The study, the larger generation study, had made some assumptions which actually aren't totally coming out in the data, that younger people would look better in terms of minority stress and mental health, given that they're part of this equality cohort, they've grown up seeing representations of themselves. So that was one possibility. Another possibility, though, was that maybe you'd see the reverse, that the pride cohort, because they've been around longer, they've grown accustomed to how to manage stigma and stress, would report less of these stereotype threat phenomena. Yeah?
Why are there gaps between the years?
It's a great question, and it drives me crazy. It's why it's very hard to be a part of someone else's study, because you're like, why did they make those decisions? I don't have a great answer. It's just when they wrote this grant, what they chose to do. They chose specific cohorts that were based on specific events in history that might define what these cohorts are, and that then, for whatever reason, left these gaps in the ages. Okay, let me just, here are the participants, and let's just get to the blah, blah, blah. Okay, I just want to show you this measure real quick, and then we're going to just look at the results. So we used a 4-item measure that we created to assess explicit feelings of healthcare stereotype threat. I worry about being negatively judged because of my sexual orientation or gender identity. I worry that evaluations of me may be negatively affected by my sexual orientation or gender identity. I worry that diagnoses of me and my health may be negatively affected by my sexual orientation or gender identity. And I worry that I might confirm negative stereotypes about LGBT people. Importantly, for this sample, we only did sexual orientation, not gender identity. There's a separate sample that included trans-identified folks. So none of these people identify as transgender. So there we go. We measured both mental health and physical health, as well as what I'm calling engagement with healthcare providers, which as a proxy, I looked at how out you were to your healthcare providers. And I'm just going to get to the results. Okay, so here are a bunch of controls. So stereotype threat, importantly, predicted how many poor physical health days participants reported. So the higher your self-reported stereotype threat, the more in the past 30 days you reported poor health physical days. Also, increases in the number of health diagnoses. So across 23 health diagnoses, ranging from cancer to asthma to heart conditions, more reports of stereotype threat, marginally significant increases in these health diagnoses. Importantly here, cohort is not moderating these effects. So the link between stereotype threat and these outcomes isn't changing based on cohort. You see the same pattern with mental health. Psychological distress, more stereotype threat, increased reports of psychological distress as measured by a measure called the Kessler-6, and lower amounts of life satisfaction, the satisfaction with life scale. The only interaction that was significant in these results, looking at cohort as a moderator, was with life satisfaction. And interestingly, it's the younger and middle cohorts that are more reactive in the face of this stereotype threat. So they're demonstrating poorer life satisfaction when they're reporting stereotype threat than is the older cohort, seeming the older cohort is less reactive. They're experiencing this, but isn't reacting as much to it. The final slide I'm going to show, and then move on so other people can talk. I did at the end, as I grew more interested in these cohort differences, just wanted to look at the difference in the self-report of stereotype threat. And you do see differences by generation here. So here you've got the two comparisons with the younger versus the older and the middle versus older. And what you see here, oh, sorry, this is not it. This is the last slide looking at outness to doctor. Same thing. More stereotype threat, less disclosure of your sexual orientation to your healthcare providers. This is the slide looking at stereotype threat based on generation, and you see significant differences with older generations actually reporting more stereotype threat than the younger and middle. Younger and middle don't differ from one another. So even though they're reporting more stereotype threat, the older generation, they're not as reactive to it. They're reporting experiencing more of it, but it's not affecting them as much. So in summary, self-report of healthcare stereotype threat significantly related to poor mental and physical health and to lower levels of sexual orientation disclosure. Individuals in the younger and middle cohort report more healthcare stereotype threat than individuals in the older cohort. But despite cohort differences in reports of healthcare stereotype threat, cohort did not, for the most part, moderate links between healthcare stereotype threat and the outcomes. I'm going to leave it at that, so we can move on and then do questions at the end.